Okay, so this patient is 55 years old and
Okay.
he's diabetic, end-stage erectile dysfunction. He was not responding to medical treatment, so we decided to put an implant for him, a malleable implant. People are familiar with the penoscrotal approach and the prepubic approach. عايز فتيلة تانية غير دي. Penoscrotal approach and the prepubic approach. So I thought to show people another approach which is beneficial in certain situations, the degloving approach. From my own point of view, the degloving approach is beneficial in certain cases when the penis is very narrow and you need the corporotomy to be accurate, not to injure the urethra. This is the first one. The second one, when there is extensive fibrosis and you need, like the post-priapism cases, and you need to do a very lengthy corporotomy from here to there. So degloving will enable you to do a very lengthy corporotomy incision and deal with the fibrosis. So I thought it's nice. It's a nice to show people another approach which make life easy for the beginners as well. The other
د.خالد.
yes.
دكتور محمد مصطفى مع حضرتك.
اهلا وسهلا دكتور محمد.
الله يحفظك. Sorry for starting late as Amr said, but
No problem.
regarding the degloving
Yes.
incision, I mean, is there other way to deal with fibrosis, away from
Yes.
doing
There's
a big corporotomy?
Yes, there are always other ways like using the
Scissors,
the scissors for scratching or the Rosello dilator to cut down the fibrosis. But sometimes you need to extend your corporotomy. So you can do penoscrotal incision longitudinally or do the degloving. And the degloving, from my own point of view, make life much easy. The third indication is when there is a concomitant indication for degloving, like doing penile lengthening. So if the penis is very narrow, this is the first indication. If there is extensive fibrosis and you need to do a lengthy corporotomy, this is the second one. When you need to do another job like penile lengthening, this is a third indication. So it's nice to have an alternative option. You have got many options now. So as you can see, we've done the degloving and we've taken stay stitch at the corners, and we dilated the corpora, alhamdulillah, very easily to size 13, and we measured a total length of 22, guys, 22. So we will cut the implant now on 22 and then modify this. This is another point, how to assess the total length that you're gonna put inside the penis. Some people add length, other people subtract half a centimeter, some other people subtract a centimeter or more.
Yeah, this is my question for you. In your practice, you are putting the same length, or you subtract like half centimeters also?
Okay, from my own point of view, there is no absolute rule. There is no absolute rule because anatomy is different. Some people, you put the same length and you find yourself in need to put an extra length. And other people, you put the same length and you find yourself in need to subtract length. So from my own point of view, anatomy is different. There is no absolute rule. It's not wise at all to put an absolute rule, like saying, I'm going to subtract half a centimeter from everyone, or I'm going to subtract a centimeter from everyone. It's not correct.
So
you should modify yourself according to the anatomy.
Okay, so what is the guidelines? What is the governor for that? Is when I do the same length, when I get back like 5 centimeters more or less, what is the ruling here?
I didn't get your question.
No. I mean, when to put the same length, when I bought a subtract like half centimeters, when I bought an extra length with extenders. I
will show you this practically now. If you find the tip of the implant away from the first third of the glands, this means it's a bit short. And there is other test that you can use. You can move the implant from inside using a DeBakey or Babcock to see whether or not it's short. If it's long, you will find a kink from the corporotomy. and you find the implant exceeding the proximal 1/3 of the glands. So you assess, after you put the implant the full length, you assess. We are preparing the implant now. انت عملت ايه؟ دي ايه دي؟ دي زيرو، دي الستاندرد تاب. So ما اعرفش الكاميرا مبينه ولا لا.
Okay.
This is the 22 centimeter implant. We cut at 21.5, 22, and put the standard rear tip. So the total length now is 22. يلا ساعدني. I would like to put the proximal part first, and then من بره كده, from outside you feel it's nice.
It's fitted.
Yes. بسم الله.
Khalid.
Now,
What
as
about
you can see, it's a bit long. As you can see, it's a bit long. There's kink here. So I would like to subtract 1 centimeter from this one. Okay.
What about the girths? How you choose the girths?
حطها وشيل سنتي. Yes, sir.
Girths. How you choose the girths?
Well, before you join us, we dilated serially until we reached 13 size Higger dilator. شيل سنتي كامل. 13 size Higger dilated. We put the Higger dilator on both sides, tested for crossing and tested for the size.
Yeah.
You do the bench test. You put your fingers here at the back of the penis, and you feel the space between both dilators.
Between the thumb and the index, right?
Yes. If you can put the tip of your fingers slightly between the dilators, that's fine. If there is a wide gap, that means the size.
You have to increase the girth, right?
Yes. You assess according to this bench test. Okay. So we subtracted 1 centimeter, and we'll put it again. Bismillah. Now it lies very nicely. Okay. And reach the proximal 1/3 of the penis. هنقص الثانية برضو بنفس الطريقة. We'll go to the other side. As you
nice, Dr. Khalid.
As you can see, the degloving approach makes life easy, especially if there is fibrosis. 21.
Dr. Khalid.
ازيك يا دكتور عمرو؟
اخبار حضرتك ايه؟
الحمد لله.
In your experience about the irrigation solution you use during the prosthesis implantation.
Well, when I was working at the UCL in London, we used to use rifampicin, which makes the irrigant orange in color. But here in Egypt, rifampicin is not available, so we use garamycin. Flush, please. So I think now the implant is okay. It lies nicely in the corporotomy incision with nice axial rigidity. I'm thinking to subtract more half centimeter, to be honest with you.
Dr. Khalid.
Yes. And she must.
Is there any relation between the post-operative pain and the size you put? I mean, it's the same size. It's subtract less or more. Is there any relation to the post-operative pain with the lens you put?
Actually, it's logic that when you put a longer implant, the patient will suffer from more significant pain after surgery. But there are other factors like diabetes. Diabetes itself and peripheral neuropathy, as in diabetes and peripheral neuropathy is a cause of post-op pain. So I think counseling of the patient is very important. You should tell the patient that you may have some pain post-op, especially if he is diabetic. And in terms of the intra-op tips and tricks, you shouldn't put a longer implant than proposed. So I subscribed subtracted more half centimeter to avoid what you have said, to avoid pain and stretch over stretch after surgery. So now we ended up with 20.5 total length. In some cases, that's why I've said, in some cases you add length. In this patient, we subtracted length. It's easy to subtract than to add.
And I see a little bit longer carburetum, so you don't need to put some sort of elevation to put your prosthesis, right?
No, yes. This wide corporatomy.
This is because of the bigger size or longer corporatum, right?
Yeah, yes, the lengthy corporatomy make your life easier. So we have done the implant. Now we're gonna close the wound. فيكريل 2-0 بعد اذنك. And wash. عايز الفيلد يبقى نظيف. So we're gonna close the corporatomy now, and then close the wound in layers. The patient will have a mummy wrap overnight, and the catheter should be placed overnight as well. Next morning, the patient do a TOC, trial without catheter, and if he can void normally, he can go home. بسم الله. حاجة أصغر من دي لو سمحت. So the idea that the message that I wanted the audience to receive is that we have got another alternative than penoscrotal, subcoronal, and prepubic approach. We can do the degloving if the patient has a narrow penis and the dimensions are difficult to deal with, or the patient is post-priapism and there is extensive fibrosis, or you are in need to do penile lengthening at the same time of surgery. So it's nice to have alternative weapons and to know all approach.
Yeah, I agree. You have to have like many approaches when indicated to shift from one to another. Regarding closing the carburetomy, your way is to make it interrupted. Not continuous.
Yes, many people do it continuously, but me myself, I don't like the continuous stitch because if it breaks up, everything is broken. And the patient comes post-operatively with a gap. You can feel a gap in the tunica albuginea. But if you do interrupted stitch, if one breaks up, the other will stay.
Regarding the irrigation, I mean, you may use irrigation, of course, to get the clots out. Is there other benefit from irrigation, like to test for perforation, for example?
Yes, we have done this before you join us. We did the irrigation, and there was no fluid coming out of the meatus. So we concluded that we didn't do distal perforation. Also, we put the dilators on both sides, and we tested for crossing or perforation, proximally and distally. I'm not sure if you have seen this.
No, we joined you late actually.
Okay.
So what your recommendation in general, like take-home messages? I mean, the good advice we should take from at any case, I mean general rules.
Well, my take-home message, as I've said, there is an alternative approach, which is degloving, and I've said the indications of this. The other general approach is the patient selection and counseling. This is for juniors. If any junior urologist is listening to me at the moment, patient selection and counseling is crucial. We have got at our university, at Tanta University, a patient who had an inflatable penile prosthesis for free, and the patient is unhappy after surgery despite being complication-free. So the surgery went very well, and the patient had the implant for free. He didn't pay a penny for this. And the patient is unhappy because he was not properly counseled before surgery. He had no imagination about the inflatable prosthesis, how to operate it, the parts of the prosthesis. So always undersell and over-deliver. Undersell, get your expectation, the expectation of the patient low, and over-deliver the service. Do your best to do a very good surgery with no complications, with high efficacy, but over-deliver, but undersell, sell the expectations of the patient.
Yeah, actually, the patients should have real expectations for what he's going to do.
Yes, completely agree.
In your opinion, do you have any explanation for the shorter size after the penile implant?
You mean the patient complaining of having
shorter penis, yeah.
Well, from my own point of view, the patient is comparing himself at the moment to what he has in his young age. The patient is 60 or 70 years old, and he was expecting himself to have the same length when he was 30 or 20. So he
I mean, this is this is not the point. I mean, he just compare his status like 1 or 2 years back, not necessarily to be like many years ago.
No, yes, 1 to 2 years back, he will have the same length. He will have the same length. And the people always are needing larger penises. So,
but there is no actual decrease in the size, because this is a common and well accepted complaint for the patient.
No, there is no actual loss of length because of the penile prosthesis. The patient perception of his length is the problem. His perception of the length is not accurate.
What about the sensation, even in non-diabetic patient? I mean, do you have an explanation for that? Although, like here, we use scrotal or degloving technique, meaning there is no way to affect the sensory supplies of the penis, and in a part of this is still the patient complaining of like lack of sensation, especially in the glans and distal shaft. Is there an explanation for that also?
So, well, I will tell you a story. My PhD degree was about inflatable penile prosthesis safety and efficacy. I went to London, to University College London, and I did more than 300 inflatable penile prostheses with Mr. David Ralph and Mr. Sachs Minhas. And I have assessed safety and efficacy of inflatable penile prostheses in more than 300 patients. The surprise is that the conclusion of my PhD thesis was that penile prosthesis is the gold standard treatment for erectile dysfunction, end-stage erectile dysfunction, but not without complications. Not without complications. Complications can always happen. Surprisingly, a very significant percentage of the patients were complaining of what you have said, paresthesia of the glands, cold the glands, discomfort, things like that. Here in Egypt, we complain of the big things like infection, mechanical failure, and that's it. But in Western countries, they very commonly complain of cold glands and paresthesia. I think the cold glands cannot be avoided if you dilate the corpora cavernosa. The paresthesia happens especially in diabetic patients. And it improves with time. So you should reassure your patient, ask him to control his diabetes properly, because diabetes, as you know, leads to peripheral neuropathy. And you can give him neurotonics to control his pain.
Regarding the cold sensation,
Flush.
I mean the use of like
PDE5.
5 alpha, yeah.
Yes.
Can it help in this regard?
Yes, it can. We prescribe PDE5 inhibitors, tadalafil 5 milligram
As a
Tadalafil
continuous use.
as a continuous use, and it always improve within 6 months.
But the patient can argue against that I did a prosthetic surgery and I should don't use medication anymore. Yeah.
Yes, we will convince
this is a
them
problem. Yeah.
this is a temporary situation, and if you control your diabetes and let time go, we will stop the treatment.
Thank you, Dr. Khalid, about this nice illustration for your case.
Always pleasure. Flush, please. We are while closing the corporotomy, we do flushing with antibiotic, especially in the implants which are hydrophilic coated. أطول شوية.
About counseling with the patient, Dr. Khalid.
Yes, Dr. Am.
I agree with you, and I add counseling for the female partner, which is very, very important.
Yes, I do agree. I have got some patients whose wives refused to attend the clinic, and after doing a very excellent surgery, the patient comes back saying, I'm not happy and my wife is not happy. Because the wife is unhappy, is always unhappy, but sometimes it's unhappy because other things other than his erection and his sexual performance. So after you do an excellent penile prosthesis surgery, she is still unhappy because something else. So the patient keeps coming, complaining, I'm not okay. So incorporating the female partner in the pre-op counseling is crucial. I do agree with you, Dr. Amr.
Okay. For my colleagues, Dr. Khalid, what about the use of this semi-rigid penile prosthesis for sexual intercourse post-op?
I didn't get you the question. What about the use?
What time you give permission for your patient to go for intercourse?
طويل. So after surgery, the patient stays at hospital overnight, and next morning we remove the mummy wrap and we remove the catheter, and the patient can void without difficulty. We discharge him at home on co-amoxiclav for a week. Okay, we give this patient pre-op antibiotic, Epigent and ceftriaxone. The patient is asked to come to clinic to check the wounds after a week or two.
Regular visits.
And the patient is asked to abstain from sexual intercourse for 6 weeks. To abstain from sexual intercourse for 6 weeks. Now we have done, we close the corporotomy. Okay. We have done. Now we'll remove.
It looks fine, Dr. Khalid.
Habibi, thank you.
Regarding the sexual act post-op, Dr. Khalid, is there any recommendation for the patient? I mean, like positioning, certain positions should avoid?
No, to be honest with you, the patient after having penile prosthesis surgery wants to be completely free in his sexual performance. So there are no certain sexual positions prohibited after penile surgery, but as you can know, the cowgirl position is always dangerous, even in normal patients with no prosthesis.
So you recommend like the regular way or regular position, like?
Yes, but I always advise the patient. I always advise the patient to go slowly in the first instance until he is familiar with the sensation of the prosthesis and his wife is familiar with the sensation of the rigidity of the prosthesis. So the first few times should be very slowly. So we are done. Now we get the skin back and we put the mummy wrap, and that's it.
Good job, Dr. Khaled. Last question for you. Sometimes you do like a great surgical procedure and same time post-operative when the patient practice his sexual activity, some sort or some complaint that there is some sort of rotation of his penis or instability. And sometimes he is very annoying of that, very distressed of that, and even his partner is the same, do the same way. Is there an explanation? I mean, is it related to the girth, to the length, to the stability? What is the problem here?
Well, from my own point of view, it's related to the penile length. If the patient has a very long penis, then he will have some sort of instability. And when you tell the patient your problem because your penis is very long, he will be okay. He'll be happy.
Sometimes he is not happy with that because the rotation or instability makes some sort of frustration for him, actually.
Yes, I know, but we will come to the first point again. Gift. We will come to the first point again, which is counseling. When you should counsel the patient for every single complication that can happen. The instability, they call the glands, the infection, the mechanical failure in inflatable one. He should have a real expectation. Because instability, if you put a proper size of the penis, cannot be avoided.
In your practice, Dr. Khaled,
yes.
What time you permit for your patient post-op to flex and extend the penile implant?
Well, I think after 2 to 3 weeks.
Yeah.
When the corporotomy has healed. When
it is important for the patient to do this.
Yes, I believe it's important to break fibrosis and to minimize pain. And usually I do it myself in the clinic. And I don't allow the patient to do over manipulation of the prosthesis before 6 weeks. So myself, I do the flexion and extension.
After pseudo capsule to be well
yes,
formed.
Yes.
And now we ask the floor if there is any question from the floor.
عايزين حاجة نقفل بيها السكن. فايكر رابيد 4-0 لو موجود أو مونوكريل 4-0.
Good job, Dr. Khaled.
Thank you, sir. Thank you.
Dr. Khaled, you close the skin with absorbable or non-absorbable sutures?
Absorbable. Vicryl Rapide 4.0. Vicryl Rapide 4.0.
I think
now
we end this transmission, Dr. Khaled. We have 1 minute only.
Yes.
I want to thank you for this great job.
Always pleasure, Dr. Am.
Great illustration.
Thank you, Habib.
And your team.
Thank you, sir. I would like to thank the team, by the way, Dr. Mahmoud Abdelaziz and Dr. Mohammed Zidane. They are assistant lecturer of urology in Tanta University. I had the honor to have you today. Thank you for assisting me.
Great team, by the way.
Thank you, sir. I want to say another important point. You are good as your assistant permits. The assistant is crucial. It's very important. If you've got a good assistant, you do a very good surgery. If you have a bad assistant, you do a very bad surgery. You are as good as your assistant permits. فالفضل لله سبحانه وتعالى ثم لدكتور محمود ودكتور زيدان. وطبعا التيم والانستيزيا والتمريض بشكرهم جميعا هنا في مستشفى المطرية، كانوا فوق الممتازين الصراحة. شكرا جزيلا.
As you know, Dr. Khalid, we joined late.
Yes.
About what your advice about scrubbing of the patient?
Yes, we did a 10-minute scrub using betadine soap, and then we used chlorhexidine, because studies tells us that the chlorhexidine is more effective than betadine in preventing infection. So I would like to use both betadine and chlorhexidine.
Combination.
Yes. And we gave the patient antibiotic combination, Epigent, garamycin, and ceftriaxone, Kev and Gent. This was the same protocol that I used to use in London. Kev and Gent, ceftriaxone and gentamicin.
Please give your colleagues advice about shaving.
Yes, sure. Regarding shaving should be done on table. If the patient shaves at home, this will lead to colonization of bacteria and increase the risk of infection. So penile prosthesis, shaving should be done on table. To be honest with you, this patient was shaved already, so I didn't shave him on table. إن شاء الله أموره تبقى كويسة.
Okay. Dr. Khalid, you can give an end message for your audience in the hall.
Yes, for take-home message, you have got the degloving approach as an alternative. You can use it if the patient has a narrow penis or extensive fibrosis, or you are planning to do penile lengthening at the same time. The most important point in penile prosthesis patients, from my own point of view, is counseling. You should undersell and over-deliver.
Thank you very much, Dr. Khalid.
Always pleasure.
Thank you.